Welcome to another exciting lecture from our stay-at-home class. This chapter is rather boring when we are all together to make jokes and rude comments. It's going to be a little bit more boring in this particular manner. A lot of us are not aware of how many people are at home with respirators and other devices of sorts.
Hello, Shay.
And at times it could be kind of almost confusing to walk in a room in a nice house or even a shitty house and find somebody in a hospital bed hooked up to a feeding tube or something of that nature, or a vent, or both. It is important not to be distracted by that equipment, to be prepared to deal with it and understand hopefully something about it enough to where you could package the patient and transport them. You need to focus on the patient and whatever the acute issue is. Intellectual disability. This is where I would generally insert some sort of incredibly crass comment, but I'm going to have to let your imaginations do that today, given that I do leave these public, and the last thing I need is an outcry for my ridiculously crude remarks. So insert your here. A lot of families have intellectually disabled members that live at home throughout their entirety. So this could be anything from a toddler up to a 60 or 70-year-old individual, and they can add a certain level of difficulty in treating them. Slight impairments are the most common to see in the private home setting. It's something where you sort of have to try to engage the patient, and depending on their level of disability, you might have to approach them as if you would a pediatric patient. Definitely involve the family and get their advice on how best to approach and communicate with them. And there it is. Rely on patients, family members. So you can rely on the patients at some levels. Other times it's entirely on the caregivers and family members. Difficulty adjusting the change or breaking a routine. This could be extremely difficult to deal with. You are about to take the patient out of their normal. Just the fact that you walked in is a disruption to their normal. So you need to be aware of that and try to act appropriately. And obviously, they're susceptible to all the same diseases. Remember, viruses don't discriminate, nor do any other ailments. Mildly autistic patients are generally fairly easy to approach and care for. A lot of times you have to allow them extra time to run through their motions, whatever they might be. Severely autistic, the bottom dash, hyper and hyposensitive to sensory stimuli, you need to be very aware of that. Sometimes the autistic will have major issues with you touching. You need to, again, gauge each patient as an individual and try to tailor your efforts and care to their needs and willingness to receive intervention. The big take home from this slide is the bottom dot. Rely on parents, caregivers for information. And these patients tend to do the best with simple one-step directions. Take it all one step at a time. If you need them to get on a stretcher for you, you want to start with, could you stand up? And then, can you move over here? Then, once they move over there, can you sit down? So you need to be very slow and methodical with them. Increased risk for medical complications, something we need to be aware of. Heart conditions, hearing and vision problems are very common. And their intubation might be difficult because of the tongue. Getting an oral airway might be difficult. You might have to go with a nasal airway, and a mask ventilation. It's just difficult because of the physical shape of their lower jaw and upper jaw. So making a seal could be more difficult. And these are yeah, management of seizures is the same. It doesn't matter what's wrong with them. The atlantoaxial joint is unstable in approximately 15% of patients. There is a really good training video on YouTube that I will add to this chapter tab and navigate to. So take a minute and look at that. It is something that it would be good if you're aware of. And it's, I mean, 15% of patients doesn't seem like that big a number, but just the same, there's a good chance that any Down syndrome patient you have may suffer from this, and you need to treat them with a little bit more care. You should also highly suspect neck injury for any trauma whatsoever. So it's normal to feel uncomfortable. We can't feel uncomfortable. We got to work through that. It is up to us to walk into the house of somebody we've never met before and treat them like we've known them forever. Whatever their physical or mental disabilities are, it's up to us to overcome and just look past it and treat them like any other patient at whatever level of treatment they could handle. So we don't need to be uncomfortable. Calm and friendly manner is how we should approach every patient, always. Introduce everyone, especially your Down syndrome patients. They're going to want to meet you. Move slowly. We don't want to startle them. You know, it's sort of like coming upon a bunny rabbit. Get run away. Watch for signs of fear, soothe anxiety, establish trust and communication. These are things you should be doing for every single patient, not just those with specific disabilities. Brain injuries may be difficult to treat. These patients could be all over the place. Some are very repetitive, some are very anxious. A patient with a traumatic brain injury could present in any myriad ways. So we need to, again, establish a rapport and try to work off of the feedback they provide you. Explain everything and reassure them. Again, just like every other patient, but a little bit more so. Visual impairment, patients that are blind or partially blind, we should really increase our game as far as verbal communication. You should explain to them where you are. You should be sure to use your words to paint a picture for everything that's going on. Sometimes it might be difficult to recognize. You won't know that they're blind until you ask them if they could see this, and they say, no, I can't. And you say, why? And they say, because I'm blind.
She knows way more than I.
Hearing impairment. What? My favorite joke, when they say they're hard of hearing, I say, what? And sometimes you could get them to say it at least one more time. It's great.
128 Central Avenue, 128 Central Avenue, 58-year-old female, and pending seizure, 32 at 1333.
Many older people have some form of hearing loss. Absolutely. Bye, baby. Have fun. Assist the patient in finding and inserting their hearing aids. I believe we've discussed this. Generally, the family wants to leave the hearing aids home. We want the hearing aids to come with them. And it could develop into a bit of a disagreement where the family doesn't want the hospital to lose them and you want to be able to communicate with the patient. So try your absolute best to make sure that the patient has their hearing aids with them. Do not exaggerate your lip movements or look away. So you want to look at the patient. A lot of patients, even if they don't read lips, they don't know that they are reading lips, at least partially, to help them understand what you're saying. Be directly in front of the patient. Be close enough. We're absolutely supposed to teach you not to yell at your patients, but there's a lot of times when speaking loudly will help them hear you. So this is something you have to gauge with the individual patient. And if you speaking at a yelling level will help them understand you, then by God, do it.
Responding. 1334.
You like my chair?
Yes, I like your chair very much. Lowering your pitch is often very helpful. For the most part, you women with your high tones
Hello!
are very hard to understand for someone who has hearing impaired. American Sign Language, sure, learn it. It can only help. And for the rest of us, we can write notes. Yeah, there's lots of types of hearing aids. I don't care about telling you about them. There you go. There's some pictures of hearing aids. Cerebral palsy, group of disorders characterized by poorly controlled body movements. Keep a close eye on the airway, suction, obviously, if necessary, and don't assume that they can't think. They're more prone to injury. Unsteady gait is absolutely a thing. You need to be aware of that and be sure to support them. Sometimes they will present with weirdly shaped extremities. Assume it's normal until told otherwise. And take walker or wheelchair with the patient. So this is a very difficult situation. In our ambulance, legally, we are not allowed to carry anything that cannot be secured safely. We cannot secure walkers and wheelchairs. In the event of a collision, they will end up being a danger to everyone in that bus. So if there's family members or a Howard around that could transport that item, by all means, have them take it. Okay. Spina bifida is one of those unique ailments that could be hard to manage. A lot of these patients are bedbound and fairly immobile. Severe cases, everything has to be done for them, and they tend to be rather prone to other illnesses and conditions. So just be aware and be gentle with them. Extreme latex allergies, for whatever reason, it tends to be a thing. That was a real big issue 20 years ago when we were still using latex gloves. Most of these patients you could not treat with your gloves on. You had to treat them with bare hands because we did not have hypoallergenic gloves. Paralysis is inability to voluntarily move body parts. We know this. There could be lots of possible causes. There's nothing to gain by going through a list here, other than it could be born with, it could be caused by. Diaphragm not functioning correctly could require a ventilator. Normally, if there's a paralysis and they're on a ventilator, it's because the injury is in the cervical spine. Remember, most of your controls for breathing are up there, and if that gets damaged, then the body might not be able to breathe on its own. A lot of times, these patients with cervical level injuries will require a great deal of suctioning on a regular basis. So there's all kinds of stuff that you could see in these patients. Urinary catheters are very common, trach tubes, colostomy bags, and feeding tubes are all quite common. Ask the patient and their caregivers the best way to move them. Don't ever be afraid to get advice and support from the caregivers that are there, or the patient themselves. They know their condition. They know what works well for them. Obesity. You don't have to look any farther than me. Yeah, I love it. Imbalance between calories consumed and calories used. I do have an eating problem. I love to stuff my face. Sometimes low metabolic rate or genetic predisposition. Some people are just meant to be fat. The big issue with bariatric is that a lot of health problems and comorbidities will present themselves solely to the fact that they're overweight. Diabetes being a big one. Additional resources like
14 on scene and 70.
like
14-3-470, 1340.
fire truck drivers to pick them up and put them down. Treat them with dignity. Don't be afraid to make jokes, just like you would with any other patient. Well, just like I would with any other patient. Avoid trying to lift the patient by one limb. I don't know if they mean using one of your limbs or using one of their limbs. Either way, both are bad plans. And coordinate and communicate all your moves. You should be doing it with countdowns and whatnot. I don't understand. The timer on this is counting down instead of up. I don't understand. But I guess it doesn't matter to any of you. Interactions with patients with obesity continued. Pinch your pressure points for equipment, and be concerned that if you cause ongoing pressure, you can cause a deep vein thrombosis. Difficulty breathing if you lay them supine, that's absolutely a thing. And carefully plan your route of travel. I mean, if you're bringing somebody out on a backboard, make sure you have the route mapped out and planned, that there's nothing in the way, and that all your team members know how you're doing it. Give early warning to the facility that you have a bariatric patient. They're supposed to get a bariatric bed, which is basically just wider. Trach tubes. This is something that I feel like we discussed already in this class. I will be sure to put the trach change video on this tab as well. We are not actually allowed to, within our scope of practice, to suction out a trach, but a lot of these patients do their own suctioning on a regular basis and may need you to assist. The video shows pretty clearly on how to suction, but it's something you should be aware of. And there are situations where, even though it's outside of our scope, it's absolutely important that we're willing to manage a tracheostomy appropriately. It's basically, the tube is just a mechanical airway that keeps the stoma open. And we do need to be aware that they're very prone to obstruction by mucus more than anything else. I have no idea what the dope mnemonic is. I'm interested to learn. Hopefully it'll be in here. Otherwise, I'll actually have to read the chapter. Mechanical ventilators. Patients who cannot breathe on their own will have one. This is something that could be in a private home, especially, quite frankly, in your more affluent communities where family could afford 24-hour caregivers. If they do not have some sort of mechanical ventilator that could travel with you in the ambulance, then you're probably going to have to switch to the BVM and bag them. Hopefully they will have an airway in of some sort, whether it's an ET tube or a trach, that you could connect your BVM to and breathe for them easily. If not, if you have to use just your BVM, hopefully you can make a good seal and breathe for them all the way to the hospital. Apnea monitors. Preemies, this isn't something you should see at home, but every once in a while it is possible. Between 2 weeks to 2 months after birth, it will alarm if they're not breathing, and it should remain with the patient throughout transport. Pacemakers are very common. They're about the size of a half a deck of cards, and they'll be implanted under the skin, generally in the top left above the heart. So opposite where we put the defib pads, which is one of the reasons we put the defib pads where we do, is because the pacemakers are always going right above the heart. and we do not want to put a defibrillator pad directly over a pacemaker. That would be very bad. LVAD, I will also put this video on Jones and Bartlett, assuming I can. The LVAD is becoming more and more common. We went over this a bit in CPR training. For those of you that could remember CPR training, it's a stopgap measure until they could get a heart transplant. And some patients get this and live a very fruitful life all the time. For the most part, we're going to treat this patient just like any other patient. We could do CPR on them, though it's probably not going to work because fluid's going to be pumping through their LVAD pump. Use the caregiver or medical control as a resource. There's a good chance that with our Band-Aid stations as our sponsor hospitals, we're going to get better advice from their caregivers. Anybody who's going to be a caregiver for an LVAD patient has to go through training, and every LVAD patient has a go bag. The bag has to go with them. It has spare batteries, chargers, and other connectors and stuff that they have to have. You should never ever assume that they'll be able to get gear for their LVAD at a hospital. It's just not going to happen. You have to bring a go bag with them. Defib vests are great. They're basically a defibrillator that the patient wears all the time. It will have a monitor that'll tell you if shocks are going to be delivered. The vest should remain in place while you perform CPR. You can put your defib over it. There is a chance that the battery, if they get shocked a bunch of times, there's a chance that the vest battery will wear out. It'll be spent, and you will need your own defibrillator. Central venous catheters. Basically, it's IV access that's there all the time. We also call them central lines, which is how most of you, if you've ever heard them referred to, it's going to be a central line, and it's going right into the vena cava. So there's one. That would appear to be a triple lumen, meaning it has 3 little tubes in it. G-tubes are tubes that go directly into the stomach to provide fluids, food, or medication. Basically, these are patients that can no longer swallow and eat or drink. So they bypass the whole mouth-throat combination and go directly to the stomach through a tube. They can become dislodged, they can become clogged, and those are reasons why you will be called to the scene to transport these patients. There might not be anything else wrong with them, but their G-tube's clogged, or it got hooked on something and it pulled out. Assess for signs and symptoms of bleeding. It's definitely a thing. If they seem to have bleeding, you need to try to control the bleeding. Understand that it's mostly internal, and the best thing you could do is rapid transport. Be prepared to suction these patients. Clearly, if they have a G-tube, there's something wrong with their throat, their mouth, the esophagus, the muscles around it, the cartilage. We don't really know. So we need to just be aware of that. Shunts. There are lots of different kinds of shunts. The main shunts we're going to see are the ventricle shunts.
Transporting one.
So if there's any question about a shunt in their head, you can palpate behind the ear, and you should feel like a little squishy spot. It feels like fluid. For the most part, you're going to know because the patient or their caregiver is going to let you know. Blocked or infected could cause major changes in mental status. It could press on the parts of the brain that control autonomic functions like breathing and cause them to stop breathing. And generally, infection is going to be pretty soon after insertion. So, people that have had shunts for 3 or 4 years are not too likely to get an infection in it. But if they've just had the procedure done in the last couple of months, that's when you'll see it. Vagus nerve stimulators are specifically for prevention of seizures. A lot of patients that don't react well to medications, or that the medication will end up getting one of these nerve stimulators. They tend to have like a little magnet keychain that will activate it. Ostomies are an artificial opening, is basically the technical definition of an ostomy. And then the beginning part of the word, the prefix, is where the ostomy is. So colostomy is colon. That's generally a bag on the lower abdomen where their poop chute is diverted to a bag. Urostomies are the same thing, but out of the bladder. Ileostomies are out of the ileum. I forget what that is. You should look it up. Make sure you know. Consider dehydration and calls for vomiting or diarrhea with these patients. Also, if they have an ostomy bag of any kind, be absolutely careful not to rupture or dislodge it. That will really ruin everybody's day. All right, I cheated. I googled the ileostomy. It's basically a colostomy, but up higher in the intestines. Colostomy is lower in the intestines.
14. Arrival ending 80430.
Stoma sites, really all these ostomy sites are very likely to get infected. And that is something you have to be aware of. Infection at the site, if not treated rapidly, if left to fester for a couple of days, can lead to sepsis. And that's generally the time at which we get called. Urostomy is the surgical opening in the urinary tract. Caregivers are very important in these patients. They know the patient's history, they know what the patient needs, they know the patient's baseline, and you should include them in your treatment plan. They are experts caring for these patients. They're experts on caring for their patient. Determine normal baseline at the very beginning of your assessments and figure out what's different. Why did they need to call the ambulance this time? Home care is becoming more and more common. Nobody wants to live in a home. Everybody wants to stay at home. For the most part, you could have home helpers that do cleaning, laundry, maintenance, meal prep, feeding, physical therapists that come into the house, personal care providers that aren't really doing specifically medical care, but they're doing overall hygiene and personal care. You also have nurses and CNAs that could be there as actual medical care providers. Very common for us to get called by visiting nurses and get whatever information you can from the healthcare provider while they're there. Hospice care is more and more at home. Some people want to be in a facility, but for the most part, people go on hospice and go back home. We need to understand that hospice patients could still be transported and treated for something acute and then get to go back home. These patients should not just be left there to rot and die. They should be cared for, and if there's an acute situation that can be, corrected or at least managed properly, then that's perfectly good reason to bring them to a hospital. A lot of family members and patients on hospice will be fearful that if they go to a hospital, they're never going to get to go back home. And for somebody who just wants to die at home, that's a really big deal. We need to ensure that we need to, make sure they know that they could go get acute care for the acute situation and then go back home. There's no reason for them to stay and suffer due to a fear of not being able to leave the hospital again. Follow protocols, follow patients' wishes, make sure you have a copy of the DNR. If you're going to treat and transport a hospice patient, make sure you know exactly what the family and the patient are allowing, and be compassionate and understanding. Ascertain the family's wishes regarding transport. So ultimately it is up to whoever the POA is, but we need to make sure that they understand that being on hospice does not mean they cannot be treated and transported. Poverty and homelessness. It is safe to assume that somebody living in poverty or homeless is not receiving proper medical care. Infections run rampant. Generally, these patients are going to have some sort of infectious disease. I mean, hepatitis is very common. Currently, the COVID, you're not hearing about it, but it is running like wildfire through homeless populations. Because again, these people tend to congregate in little tent cities. There's absolutely no hygiene. They poop wherever they want. The other people that you could see a large number of homeless is brain injuries that won't accept proper care, and then they end up out on the streets. Mental illnesses, domestic violence victims who just have to get away and don't have anywhere to go. Your addicts who don't care where they go. And then again, impoverished families. They'll still be together as a family unit. They might be living out of a car or a cardboard box or a tent somewhere. And we need to go and treat them with compassion and kindness, do everything we can to get them whatever help we can. Regardless of ability to pay, we must treat and transport, and the hospital must treat as well. We should know our social services. I mean, Bantam has somebody who does advocation for the elderly, and he will for impoverished members of the community as well. And sometimes it's up to us to bring these families or individuals to social services attention. If you do transport them to the hospital, there's generally a social worker in the ED, and it's good to have a rapport with them. So you could walk up to them and say, hey, this is this person's situation. And it would really be great if you'd spend some time to talk to them and see if you could get them the services they need. All right, so that's it. Nice short chapter. I couldn't be any happier. We'll bebop through these questions for your review if you care to actually look at them. I mean, I'd recommend it, but you certainly don't have to. We'll just give each one a few seconds. I'd advise you to hit pause and read the questions yourself and then try to answer them. So at any point you could pause the video to actually look at these things and see if any of it is interesting to you. There is a chance that in all this stuff, some of these questions might be National Registry test questions, which is why it's good to do these reviews. I know I don't do them in class, but it certainly won't hurt you to take a few extra minutes and review the review. If anybody is still actually looking at this, take a moment and email me your favorite color. Just your favorite color. I don't care what it is. I won't grade you on it. But it would be interesting to know that you actually still had this lecture playing at this stage. All right, 8 more slides.